Welcome to the EAU podcast series, AI in Urology, From Principles to Practice. In this episode, Dr. Enrico Checcucci and Dr. Pieter De Backer discuss how artificial intelligence is transforming surgical planning and navigation in urology. Join us as we embark on this informative journey.
Hello, everyone. Welcome to the EAU podcast series on AI in urology, from principles to practice. Today, we'll be discussing AI in surgical navigation in urology, together with Dr. Checcucci from Italy. So my name is Pieter De Backer. I work as a robotic surgeon in the Aalst Hospital in Aalst, Belgium, and I'm also responsible for the AI efforts at Orsi Academy and Mantix. Dr. Checcucci is a urologist at the Candiolo Center in Italy. He's the chairman of the IAU Urotechnology and Digital Health Working Group, and he's also the representative member of the European section of urological imaging in our AI working group, which I had or chaired together with Karol Kowalewski. Enrico, welcome to this podcast.
Hi, Peter. Thank you for this kind invitation. It's a real honor for me to be here with you to discuss the potential application of artificial intelligence in the current robotic urology era.
So, Enrico, I'm very happy that you took on the invitation. We've seen plenty of your work over the last years in Turin on how you're using patient-specific imaging and how you're integrating that into the surgical workflows. And of course, AI is playing an increasing role in that field because it's automating very big parts of the manual labor. So AI is increasingly entering our operating rooms, but actually even before we are in the operating room, it can play a very big role in our preoperative CT and MRI imaging, and it can create these so-called 3D models. Can you maybe, as a starter for the conversation, walk us through how this process exactly works?
Yeah, that's a great starting point because AI actually begins its impact well before we enter in the operating room. In fact, the process starts with the preoperative imaging, typically the CT or MRI, which provides a large amount of anatomical and functional data. But traditionally, interpreting this data and mentally reconstructing the anatomy was entirely dependent on the surgeon's experience. And what AI does, it fundamentally changes this step through an automated segmentation. So using deep learning algorithms, we can now identify and isolate the key structures, such as the tumor, vessel, collective system, or neurovascular bundle. So once segmentation is completed, these structures are combined into a patient-specific 3D model, essentially creating a digital replica of the patient's anatomy. This is what we often refer to as a digital twin of the patient. So the key advantage in that this process is becoming increasingly automated, faster, and standardized, reducing the variability between the operators. What used to take hours of manual work can now be done in a much more efficient and scalable way. So in essence, AI allows us to move from a static imaging to a comprehensive, interactive, and patient-specific representation of the anatomy, which becomes the foundation for everything we do next in the surgical planning and the navigation.
Okay, that makes a lot of sense. So, and to add to that, in your experience, you've probably been doing some of these segmentations, so this coloring in these slices yourself at some point. Do you think that as urologists, as a brief side question, we should be doing if the AI predicts a certain 3D model, should we then afterwards predict it ourselves, or is there a role for, correct the prediction ourselves before we take it into surgery? Or is it a company's responsibility? Who do you think carries the final responsibility to add to these 3D models?
I think that the urologists need to have a knowledge of the imaging that they see in the operative room. So the AI can help the urologist or the radiologist to obtain the models in a faster and standardized way, but we need to have the knowledge and the capacity to understand if the result is good, is correct, and that it is in line with our clinical needs.
I agree. And I also think that AI enables us to get away from the dependency on the radiology departments.
Yeah,
And I say that with a lot of respect, but coloring in slice by slice these images by radiologists is a very time consuming and demeaning act. And with AI, we can allow, we as urologists can take on the process completely ourselves.
yeah,
So that makes a lot of sense indeed. And
yeah.
so,
Totally agree. If we can keep in our hand the possibility to elaborate the imaging of CT scan or MRI and obtaining the 3D models, it to make the entire workflow easier. So it means that we can offer to a large number of patients this technology because it requires less work before to obtain the results.
exactly. And so, we talked about these patient-specific 3D models or these digital twins. So out of the MRI or the CT scan, we get this the relevant patient information or 3D structures. So how do you use them today in the operating room? And how can AI enhance during the surgery? Because we talked about preoperatively, how the segmentation can help automate, how the segmentation can be automated. So during the surgery, how do you see the role of AI in 3D models converging?
So yes, once we have this patient-specific 3D model, the next step is bringing them into the operating room. And this is where the things become really interesting. At first, these models are extremely useful for preoperative planning. So the surgeon can explore the anatomy in the three dimension, understanding the spatial relationship between the tumor and critical structure, and plan the surgical strategy in advance. But intraoperatively, the model can be used also in different ways. At the basic level, they act as a cognitive support tool displayed on a screen or console, helping the surgeon maintaining orientation during the complex step of the surgery. But a more advanced application involves the augmented reality, where the 3D model is overlaid onto the surgical field. And this allows the surgeon to see the structures that are not directly visible, such as the deeper vessels, tumor, or tumor margin. Based on this technology, the AI can help us to do a further step forward. In fact, the AI can assist in the real-time adaptation of the model to account for the tissue deformation, can allow us for an automatic alignment between the virtual model and the real anatomy, and also can help us in highlighting the areas of interest or potential leaks. So the model evolved from being a static representation into a dynamic intraoperative guidance system thanks to the AI, supporting the decision making in real time. Specifically for this topic, we recently published a randomized control trial that for the first time demonstrated how the augmented reality images driven by the AI system can assist the surgeon in the execution of a selective biopsy at the level of preserved neurovascular bundles during robotic prostatectomy. So we observed that thanks to this assistance, the images are correctly overlapped to the real anatomy, and thanks to these images, the surgeon can selectively remove the tumor at the level of neurovascular bundle, with a significant decrease of positive surgical margins, right? Respect the 2D MRI standard group.
Nice. And so if you think about this then, so you talked about deformation. Um, it is really a key thing to have these static models of a patient that is lying flat, and then suddenly during the surgery, the patient has another orientation, or in this case, the prostate deforms a bit, or it becomes devascularized and it shrinks a bit. This is a very big challenge, and I've seen some of the work that has been published from your group where you try to track the catheter to then see how the 3D model can follow the movement. But this real-time deformation is, first of all, as we call it, computationally very expensive. You need very big computers in the operating room to calculate all of that. But secondly, being able to track all of that and model deformation is really, really difficult. So I think we both had in our efforts engineers in our rooms to make sure that at the beginning we manually align this or we track some point of that. But what are our other barriers in achieving that reliable real-time alignment. So how do we align these better? How do we account for deformation? And in essence, how far are we from not having an engineer in the room and being able to just click on our MRI or our CT scan and having that 3D model in our view, our robotic view, and doing it fully autonomous?
Oh, yeah, you already mentioned two of the main limitations that we had today before to achieve a fully reliable and automatic navigation. The first issues that we need to overcome is what we call the registration. So the capability of the system to automatically anchor the 3D virtual model to the real anatomy. Also because the colors of the endoscopic view are very similar, especially for example in prostate cancer. So it's not so easy for the system, for the computer, understand the difference between the color of the prostate and the color of the bladder and the periprostatic tissues. It's a little bit easier for the kidney, where the kidney was where the perirenal fat was already removed. It's a little bit easier because the color and the shape of the kidney are clearly visible and they are clearly defined. But this is for sure one of the first issues that we need to overcome. In fact, for these specific issues, we opted, for example, for prostate cancer, as you mentioned, to use the catheter as the anchor point for our artificial intelligence system, because the catheter is as always the same shape, is yellow inside a constantly red field of view. So the system is capable to anchor the imaging, and we overcome for this specific phase of a single intervention. We with this little trick, we overcome the registration problem. So this is the first issue that we should overcome. The second one is the real-time alignment, because all the organs change the shape, the due to the instruction of the surgeon, due to the changing of the endoscopic view. So in all that phase, the shape of the organs change, and the model should be able to follow this kind of deformation. In the past, we published on European Urology an experience where we simulate the tissue deformation of the prostate with the 3D model in a manual manner. So we introduced some deformators in our 3D model, and with a dedicated mouse, we can change the shape of the prostate during the intervention following the real anatomy. But make this process totally automatically is very, very complex, because again, there are a lot of confounders inside the operative field that the computer at the moment are not able to completely overcome. So now I think that we are in the era of semi-automatic registration and real-time alignment. So a hybrid software now can allow us to do a part of the intervention in the automatic guidance, but not the entire process. So moving forward to other limitation of this kind of surgery, one of other very important things to say is that nowadays we lack of a standardized workflow and validation. It's essential to have a standardized workflow, starting from the creation of the 3D models up to how we can use these 3D models inside the operative room. So, and also the surgeon is not an isolated figure inside the operative room. We are in an environment with other people that work with a lot of instrument and instrumentation of the anesthesiologist, of the nurse that are inside the operative room. So also there are some technical and logistical barriers that should be overcome to use new technology in a busy operative room. That said, we are making a rapid process AI-driven solution for automatic registration and real-time tracking actively being developed, and the early results are encouraging. So we are not yet in a full automatic navigation, but we are clearly moving in that direction, and likely much faster than we anticipated just a few years ago.
And so I think we're both very much research oriented, and we try to push forward these novel technologies. Um, do you see a way in which fellow urologists, which have no direct access to engineering departments, that they can use this type of technology? Because let's be honest, there is a real bridge in or a real gap in trying to get this technology in your OR if you don't have access to these resources. So is this where you think there is a need for these structured pipelines or steps where people know, look, this is the process to undertake to get to the point of surgical AI guided navigations, that there is need for a type of framework to do that, or how do you see that evolving? What is needed for this to become standard of care?
Yeah, I think like in two consideration could be done. The first one is that the urologist should have some competence, some knowledge about these new technologies, about just a preliminary knowledge, but we need to know what is it and which is the fundamental of the functioning of this technology. As well, the engineers must know which are the clinical needs of the surgeon. When we start to develop the 3D guided technology, the engineers that comes inside our operating room that did not understand which are the surgeon's needs. So with a continuous dialogue and interaction every day inside the operating room, the engineers start to think like a surgeon, but as well the surgeon trying to use the different 3D models start to understand how he or she can use this new technology that before not have in their hands. So a real important thing is the collaboration of the two different figures, because the surgeon need to know something about technology, but the engineers need to know something about the clinics and the surgery. The second aspect is important for to develop on this kind of technology is that with the homemade technology, we can try to explore new field of application. We can try to explore the potential application of a new technology, because we have the clinical feeling, but to expand this kind of technology to make this technology ready for a clinical use, also following the regulation. I think that the support of the industry that can boost the development with the incredible resources, different respect the resources of the hospital are fundamental. So the clinics and the researchers can add the talks, can have the things, of the idea, but after that the industries should be at our availability. They should collaborate with the clinicians to boost the technology and to allow to achieve a standardized and very fast development of the technology. Otherwise, we can always try to maintain the same level.
I agree, and I think indeed the involvement of the industry and trying to make sure that it enters every operating room, that is really a powerful combination to have, because otherwise it will just remain a research project. And that's the unfortunate thing, I think, in the whole field of 3D models over the last 10 or 15 years, is that centers of excellence have been using the 3D models, but either without augmented reality, they were considered rather expensive. And then we have case series of the different excelling groups where there is actually the case series always stay rather contained because the models are so expensive, and it's difficult to show the evidence of really big patient numbers of saying 3D model versus no 3D model. So all series are rather small and they show evidence, and the people that are used to using 3D models say, yeah, we like them a lot because they give extra insight. But there is always a vicious circle of costing too much, not showing evidence, costing too much, not showing evidence. And I think for augmented reality, this is a bit of a similar way where the cost is even more expensive. So I don't know if you've experienced the same thing.
Yeah, I totally agree. There are two different velocity of development between the technological development and the clinical evidence development. So just to make an example of our experience, we published the first randomized clinical trial, so high level of evidence paper some months ago. But this clinical experience that required 2 or 3 years to enroll the patient are based on a technology that is already old, because the technology was created
Yeah, of course.
3 or 4 years ago. Now the technology is new, but we need to start again from the beginning because we have a new technology, but we have no clinical evidence about that. So again, if we develop a technology, we should have a partner that boosts us to develop technology as fast as possible, and that way we can follow with the clinical evidence demonstration of the utility of the technology. So nowadays, these two actors are moving with a different velocity.
Indeed. I think it's also growing as a society that this is the way forward, right? And heading towards the end of our conversation here. So these 3D models, I think I was trained having 3D models a lot. They were also my interest. So I used to make them myself, so to speak. Do you see that these surgical navigation technologies, we're now seeing, apart from augmented reality, other technologies being incorporated into our planning, which is also AI based for surgical navigation? I saw some work on predicting clamping strategies, for instance, in partial nephrectomy, taking into account patient parameters. So really getting a multimodal aspect of your patient and taking into account all resources we have. Is this something how you see the role of AI in surgical navigation? And if so, how will it impact the next generation of urological surgeons?
Yeah. So looking ahead, I do believe that AI-driven navigation has the potential to become a part of standard of care, especially in complex oncological procedure. But we are now moving toward a scenario where the surgery includes a data-driven and personalized with a real-time support system that can guide the surgeon at every step. So not just the imaging navigation. So, for example, the future surgeon will not only need the technical skills, but also the ability to interpret and interact with the digital information. So the AI can help us in the simulation-based learning using the digital twins, the objective performance matrix derived from intraoperative data, the personalized of renal function prediction, as well the personalized feedback system powered by AI. Or as we did last year, our technology meeting, also the AI can help us to predict the surgical strategy with a digital avatars that simulate a dialogue, a conversation between the surgeon and the avatar itself, that on the basis of preoperative data, training on the data of the previous operated patient, can be able to predict which is the best surgical strategy for a specific patient. So I will act on augmented intelligence, so enhancing our capabilities and potentially reducing the variability in surgical outcome. So concluding in summary, I think that we are entering a new era where the surgery becomes not only more precise, but also more predictable, measurable, and tailored to each individual patient.
I agree. I think that's a very nice bottom line and conclusion. I also think very much that because of these technologies becoming available to younger surgeons going through their learning curve, as you say, the variability of how the cases are approached will be narrowed down, and that way impact patient outcomes. But it will take us some time to collect this evidence and generate the evidence. But I think that's why we have our full career still ahead of us, right? I thank you very much for this very interesting conversation, Dr. Checcucci. Look forward to collaborating further in the Urotechnology working group and as well as in the AI working group. And I also thank the listeners of the podcast for bearing with us. And feel free to reach out if you want more information on the topic. Thank you very much.
Thank you, Peter, and thank you also to Carl for the invitation. I was very happy to be here with you and to continue to collaborate within the YAO Natali.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on the urological advancements, be sure to subscribe to our EAU podcast channel on your favorite podcast app. Until next time, keep learning and stay inspired.